Okay, we are not having a question and answer session with these two. We're going to continue the reflections of the day with our roundtable members. And since I'm a roundtable member, I will start. But you guys don't have to sit up there and wave to the audience. I am struck, since I won't just complain about primary care doctors, I am struck by the fact that much of what we heard today reflects the national problem that we have not moved the needle in 50 years on the percent of underrepresented in medicine minorities as physicians. And we still don't recruit people who grew up in small rural communities to become physicians, and on and on. Every group that has been identified as difficult to enroll in clinical trials, we don't recruit physicians from those communities. And I don't know how we're going to fix it, because it's certainly been talked about, and the efforts, I think, have been there, but there's a whole bunch of barriers that are hard to identify and easy to identify. The easy one to identify is multiple choice exams. The hard ones are much more complex than that. But the fact is that we don't have a physician workforce that reflects those people culturally, racially, historically, and until we do, we're doing all workarounds over the fact that they don't have physicians that they trust enough to be referred into these trials without constantly fearing that they're going to be either marginalized or abused in the trials. And so I don't know where that's going to lead us, but, you know, nobody has been able to pull this off. We'll see whether tuition-free New York University Medical School will attract more minority candidates. But my guess is that they became tuition-free to raise all their metrics, not to do good in terms of that particular issue. So I wouldn't hold my breath. But let me start by walking around, and we're gonna start with this end. And I will say everyone's name for the recording. So Michael McKee, you get one brilliant idea and one secondary idea.
Okay.
Otherwise, nobody will have anything to say down there.
So I appreciate all the presenters coming out today. This was, I think, a more of a difficult topic to cover, and a very much needed one as well. So obviously, I do second the comment that we really need to do a better job on our team, the clinical team, research team, to mirror our patient and participant communities that we work with. The other thing I just wanted to just highlight what Dr. Mitra said is that we need to make sure that we are inclusive in our efforts, especially for people with disabilities, just to highlight that, not just what we've already talked about, minorities, especially racial, ethnic. The other thing I wanted to just emphasize that often is not done is to inquire if there are limitations or disabilities among the patients or participants. Sometimes they're already included, but we don't know about it. And that really hurts us in terms of the data where we are looking for evidence-based dealing with this population. The last, let's see here. The other thing is I really would strongly recommend highlight the comment about the importance of having advocates, because the advocates, when they often develop the consent forms or they develop videos or go out to the community, they're often the ones that really do a better job than us trying to recruit. And they often have a better representation of who they bring. And so I just wanted to, I'll stop at that point, but I want to make sure we have a better team to work with these clinical trials.
So thank you. Steve?
Yes, Steve Rush. First of all, I want to thank the presenters of the Planning Committee and staff. This was a tremendous program. It focused a lot on health literacy and how that impacts clinical trials. I was impressed with the focus on context. And I think context is a very big issue that we need to take a look at. We talk to it, but we don't really focus in on it. I think that looking at the language issues and looking at simplifying the language to demonstrate caring and understanding is really important, because clinical trials requires people to give themselves and their bodies and their minds over to something which may or may not work. So I really appreciated everything that the people did today. I saw the optimal state this morning, and this afternoon I saw how can we take steps to get to that optimal state. Thank you.
Thank you. Jennifer?
I really enjoyed the presentations today, and I want to thank the organizers and the presenters. To me, what the issue that boiled down to today was, how do we flip it so that we have medical science serve people as opposed to people serving medical science? And I'm not really sure I have a good answer for that. I started thinking about a movie I saw a long time ago called Wit with Emma Thompson and Christopher Lloyd. And suppose you haven't seen it, it's about a woman who with ovarian cancer who enrolls in a clinical trial and what happens to her. And I think that movie is actually a very good teaching tool for the health literacy issues we've been talking about today in clinical trials. So maybe we need to revive that movie and show it. But I'm not really sure how we're going to get to where we want to go. I think having a workshop focused on it is important, and publishing the proceedings, and maybe that will generate people thinking about it in a different way, so that truly, you know, we can flip it so that medical science serves people instead of the other way around.
Great observations. Nicole?
I also really enjoyed today, so kudos to the planning committee and all the speakers. I think for me, what I saw at the beginning of the day, there are two different slides on it, though, the kind of the workflow of the clinical trial and the different entry points where health literacy can fit into that. I think that was my biggest takeaway, because there's certainly lots of opportunity and potential for us to continue to move the needle in the other direction. The only thing that I would add is kind of related to my question earlier, is that it doesn't certainly start with the recruitment of the trial, just like with other health literacy aspects. We do need to consider the history and the context of that and what that means for that workflow going forward. But in terms of ownership, I think certainly there is room for some group or body to potentially own this health literacy piece within the clinical trials. That's not my area, but certainly it seems like there's a lot of potential there as well, and that could potentially help move us forward too. So thank you all.
And Louise?
Oh, I can go. Hi,
Who's
Jay
standing
Dewick.
over there?
So yeah, well, first thing I should do is apologize to this entire table, because I think I was blocking you the entire meeting. So then, but again, second, the terrific discussion. And I think it's a testament to the focus by the planning committee to have a wide variety of speakers in terms of professional experience, of diversity of thought, and that really helped us engage across the issues and have a very complete and thought-provoking discussion. While this was happening, and what I was doing this morning is just kind of like the need and the action for this. So back at AbbVie, I have a clinical researcher that's actually working on an informed consent document. And this person's responsible for the standard safety risk language, about an 8-page section. And he's got to Dr. Williams' point, he's got to figure out how to go from, animal studies and this information to actually coming up to something that a person can use and figure out and understand the benefits and risks. And so now what he sent me had a lot of, was talking about neutrophils and lymphocytes and, the specific terms of brain tumors in mice. And thinking about it from a process standpoint, this is a senior oncologist. He does not hate patients. He does not hate people, but this is what he's got. and he's got to figure out a way to do this and be able to relate to it. So I think where we can look to engage us in process and embed health literacy practices, and I'll say this, by mandating them and by requiring them. So within things like informed consents for clinical trials, in ways that that's how we can take significant steps forward.
Hi, Ann Louise Assif. I want to thank the Academy as well as the Planning Committee, of which I was excited to be able to sit on. All of the speakers and panelists today. This is a really important topic, and as far as we've come, we still have a lot further to go. So I think after hearing all of the discussion today, I feel even more strongly that I need to go back to my world peace comment. I think there are many different stakeholders in this clinical trials arena with health literacy. All of us have the same goal, to improve patient outcomes and to help people be healthier. And we think that embedding health literacy can make that happen, but where is the opportunity to build bridges across our stakeholders to make this happen? And I think perhaps more importantly, and this is something we're grappling with at Pfizer, how do we evaluate this? How do we include new technology in these efforts? And I think that this is a gap that really needs to be addressed now so that our field can have the credibility of other evidence-based science fields. We say we expect these outcomes to happen, but we need to have the evidence to prove that. So I think the time is now, and this was a good start with this workshop today to get that going.
Thank you. I'm struck with sometimes we get confused that we make our job easier instead of their care better. And that's not what health literacy is about. Terry, I ignored that whole lane of people, so I have to like make up for this. Okay. You'll finish up. You're gonna have the last word.
So kudos. I mean, a lot has already been said between the wonderful summary that we just had and everybody's comments. But again, you know, kudos to everyone on the planning committee and all the speakers. It kind of just kept getting better and better and better, even when you thought it couldn't. So thank you. My biggest takeaway was really, I love the idea of incorporating a communication plan along with each clinical trial. So that challenges everyone to think of that as they're developing the trial and to include the plain language summary. And if we can bookend both of those with every single trial and somehow find some owner, as Nicole was speaking about, to really make that regulatory almost, you know, I hate to say that, but that has to be part of all trials, I think we could start to really move the needle a little bit.
Ernestine?
I think today was very insightful and brought so many complexities of this issue before us today. I want to just sort of highlight a few, because this morning I thought the point that was poignant to me to say health literacy empowers and drive equity. And I'm sure that that's important for all of us to take serious. And so no matter how diverse the different populations, the other message was that we recognize the diversity of the populations that's most impacted, and that's even within populations, that we don't assume that it's one fit all, and that came through in all of the presenters. Last but not least, but I tend to think we fall short of this as researchers most, is we don't really value that giving information back to the populations most impacted. So if we take anything from this, if we could flip that in some way, that the people who are most impacted would value the most, from us taking some responsibility to get the message back to them from the research and clinical trials that we conduct.
Thank you. Chris?
Thanks. I really appreciated the learning about kind of the research on informed consent that was happening that we heard about early this afternoon, and then obviously the recruitment and innovation center as well. That's just how we can think about embedding this throughout the whole continuum is really something that's always on my mind. I really liked hearing more about the module-based approach to consent. I've always been thinking about this, kind of, which is foreign to my kind, my lawyer kind. It's always got to be in one document, but I like this a lot better. I think we always think about that in the or the non-research consent world is chunk and check, with our patients and those type of things. And there's no reason that wouldn't work here. And then the other thing that really just kind of struck me today that I think I learned, and I should have known it before, I guess, is that really protocols should be plainer too. I mean, we often think, oh, we're writing them for other researchers and the folks that are going to approve our research. But I've done a lot of training for lawyers and judges in the past, and judges always say, we're so busy. Don't make it harder on us. So, but thinking about these other uses of protocols now, with clinicaltrials.gov and then using it in apps, there's a much broader audience than I think most researchers think about when they write protocols. And so there's a reason not only to kind of clarify our consent forms, but also just don't be so difficult. When you're creating your protocols, it doesn't have to be no paragraphs and 1-inch margins and 10-point font and all of those things. So that's something I'm going to think about a lot more as I go forward.
Thank you. Vanessa?
So I also appreciate the topic that we discussed today as part of some of the research that I've done. My takeaways include emphasizing that informed consent is beyond the document and maybe better conceptualized from a perspective that treats it as an educational process, uses health education principles as well as principles of community engagement so that it makes sense, and as people talked about today, is centered from the participant's perspective. I also wanted to reiterate something that Dr. Bulwer said about these hard-to-reach populations or hardly reached populations. They can be reached, but what matters for these groups that have this legacy of mistrust is that we build trust. In focus groups I've had with American Indians, we've talked about, they told me that the reason they were even in my focus group was because I had a trusted community member recruiting them. They also talked about improving comprehension by treating it more as a educational tool, and like we were doing in that focus group, and I think someone talked about it today, the PALs, having more of a discussion, a group discussion, where they can talk about the benefits, the risks, the process to the research. And then, as was just mentioned, the idea of a multi-step process where people have time to process that information. And then my final point is just that many of what we're talking about today, these findings, need to be reflected in IRB policies and in ways that these policies are actually being enforced. So needing to make sure that IRBs and researchers have tools and incentives so that they can improve the consent process.
Thank you. Lindsay?
Yes, I'd like to offer my thanks and deep gratitude to the Planning Committee and all the speakers for really helping inform us better. And I'm one of the 2 dentists on the roundtable. This was an area that I didn't have a lot of knowledge in, and I learned a lot today. My initial experience with clinical trials was actually through my mother, who was enrolled in the Women's Health Initiative for years. I remember her going for data collection periodically over like 20 years. And why are you doing that? And she said, for the betterment of women. This is so important. And she found out about that opportunity through her primary care physician, who was hooked into an academic medical center. Otherwise, she probably would never have heard about it. So it struck me when a few of the speakers mentioned that the patients who are sick, who've received a diagnosis, only 3 to 5% of them actually become enrolled in a clinical trial, and part of it is because the eligibility criteria is so restrictive, and they just don't, the primary care physician, the physician caring for the patient, just doesn't know about it. So this is especially true of patients in rural areas, minorities, and those with disabilities, and it goes back to your point, Larry, that you started off with, that how important it is to have providers that look like the population they're serving, and there's not enough of them, and that's definitely true in the oral health dental space as well. We have a serious problem with recruitment and getting dentists to go into rural areas. There are many reasons for that, but that is a significant problem on the dental side as well. There was just one other thing I wanted to mention, what I heard was how critical it is not to underestimate the importance of developing a relationship with a patient, and that takes time both in terms of the system to make the system more patient-centered and for providers to be able to have the time to spend with their patient to build that trusting relationship. And there seems to be this inherent tension between fast-tracking enrollment and and maybe funders is the driving force or whatever it is. There's this tension between that and then sitting down and taking the time to be authentic and transparent and mindful of what the patient wants. And I think we need to solve that, get rid of that tension in the system in order to make it work better for everybody.
Barry?
I've really enjoyed today and getting to know some people here. And it's a good day for me if my perspective has been enlarged and I've learned some really useful information that I can take home and start acting on. But Alicia, one of the things that you taught me was if you're a patient who's enrolled in a clinical trial, being in that trial and your health care, that's part of one whole thing. That's a part of you and your care. And things are not siloed. And we've got to, I'm always thinking about the patient perspective, but that was another layer or patient perspective of how you see things. And you've got body that has many things that are not cancer related. I like the community plan a lot. I think the Roundtable needs a communication plan. We need to think about a communication plan and how we can help drive that. I think always the communication lags behind the science and the technology. I'm not sure, I know we have to think about using new technology, but I keep going back to the relationship. So I'm not sure what that balance is. I do think the community needs an awareness of clinical trials and their importance, and I think community doctors do too, that they don't know as much as as academic docs and researchers think they do about clinical trials. And I'm going to go back and give some information to the rural patients and providers that have been in our studies, that after we enrolled them, we haven't been given information back to them.
Inga?
So I really appreciated the presentations today, and thank you to the planning committee also. A couple of takeaways that I took from today's presentation. First of all, the clinical trial fit. Because one of the things that I heard that I actually had never heard before, and probably I should, is understanding what trial is actually the best fit for the patient. And it's not just every trial that they are eligible for is what actually makes sense to the patient. And so I thought that was very important to know that, oh, wow, not every trial is actually best for a patient. And finding out from them if they actually are able to participate in the trial or not. The other thing I saw was clinical trial readiness. It was interesting to see that not every patient is actually ready to be in a trial for certain reasons. For example, they have maybe an unmet social need and that they have to be able to take care of, and whose responsibility is that before they actually participate in the trial. And then going back to something that Ernestine was talking about, I think sometimes, yes, building trust is important, reaching out to the communities of color and working with partners, but sometimes when that information doesn't get disseminated back, the results of the clinical trial, then they don't know what the results are. They don't want to do another clinical trial. So it's like we spending all that time telling them, we want you to enroll, we want you to be retained, but they had participated in a past trial that they never heard anything about, and now we are trying to get them to do another trial. So I think talking about, I think those are some of my takeaways, is the fit of the trial for the patient, the readiness of the participants to be in the trial, and then what do we do after our results, we found out the results from our trial.
That's great. Again, all about them, not us.
Hi, this is Jem Doss from HRSA. And so today I was very happy to hear about the role of federally qualified health centers in clinical trials, as that is one of HRSA's main programs. We have a saying in HRSA that if you've been to one health center, you've been to one health center, because they are in a variety of geographies, communities, serving a variety of people. And so I think the point that was made is even more important, and that is that it's important to build the relationships so that you get to know each of those FQHCs as individual organizations. The other thing I found very useful today was the discussion this morning and towards the end about language access. And when it comes to interpretation and translation, the same thing applies to computer science, and that is garbage in, garbage out. So yes, we need the English in a good shape first. I've known many folks who want translators to work on drafts, and that's the worst thing. Because drafts change, and then you make the interpreter or translator do that much more work. So, so I think it is definitely a good practice to make sure you know what you're saying in English. And related to both these issues, I want to extend this metaphor that we hear a lot, and that is the metaphor about reinventing the wheel. And yeah, we don't want to reinvent the wheel, but we do want to make sure that the tires have the right treads and it's the right size for the context we're using it for. So that's it.
It's a real challenge to go near the end. So I was on this planning committee and have been thinking about this topic for a long time. But I came and I was still surprised to hear sort of the level of conversation and what we learned. And it's sort of, I had a little bit of an epiphany as I went across the day. And I say this sometimes and get a reaction that's not positive, but I'm going to say it again anyway here. I think sometimes we work really hard to make this thing we do very big and complicated and specific and sort of create a world that no one else can possibly do or understand. And we do that to sort of generate a field. And that's important to have a field of health literacy. But here we are in this place of clinical trials, and I don't hear this being that different than the application of health literacy in many other places. And if we can take those lessons across the field, I feel like there's a chance that we could move faster together than sort of trying to have all these little subcategories of like, this is how you do health literacy in clinical trials, and this is how you do it in, message development or health insurance or whatever that is. And so that's not to disregard the need to be very specific and focus on all of our different applications, but just to sort of recognize the reality is if we listen and think about the strategies we heard today, we thought about, how do we use materials that make sense, and how do we have, multimodal materials that are available in many formats, and how do we have interventions that use sort of the power of technology? How do we build relationships that actually work? How do we keep people at the center? How do we actually care about people and pay attention to them in the right way, the way they want to? And that's an interesting thing, and it, I think, is a thread across our work. I always worry when we talk about clinical trials and health literacy that it's going to become about plain language. I thought we did a really good job today of situating plain language as a strategy, but remembering that health literacy is much more complicated, and that's really important. And then the last thing I really want to say as a planning committee member and a person that really values diversity in all forms, I want to just recognize how diverse this particular day is in medicine. And I don't know if that's something specific to clinical trials work, that women and people from lots of groups are represented differently than other places or what, but 17 of 19 speakers were women today. How about that? Like, that does not happen in science and medicine. I went to a conference 2 days ago on artificial intelligence, and I was one of 4 women out of about 300. Right? And when I opened my mouth, like, there were no heads that nodded ever. And I had that experience of like, this is what it means to be the minority. It's not that you look different, it's that people don't identify and they don't look up and acknowledge and their head doesn't nod and you feel like you should just stop talking. So that happens all over the place. But here I think this group did a really nice job. So I congratulate the planning committee for really having diverse sets of speakers that happen to overrepresent women this time, which is rare, but also having enough people who are actual patient advocates and experience and represent the population, that those voices were heard differently than they are other times when you have sort of the official nod to the one advocate. So I'm really excited about that. And the other piece of it is there was a lot of online discussion this time and a lot of engagement, which is different than other meetings that we have as well. So I think that says something about sort of who cares about this and who's here and how we pulled people in. So I'm really proud of us, and I think that's cool.
Well, thank you. I want to thank the program committee. I want to thank Melissa French and her staff. But most of all, I want to thank the presenters, because I think this was the set of presentations that was inspiring, informative, provocative, edgy, and the presenters were convincing and experts, and obviously so, and I think that created a discussion in this room that was amongst the best that I've ever seen. So thank you very much.
Thank you.